Good morning, everyone. We're live at the moment, but we're just going to give it a few more minutes to let everyone filter in and get through the joining lobby. It'll just be a couple of minutes and then we'll start. Lovely. Right. Well, that's most people in. So we'll make a start now. I am Theo Roberts. I'm the conference producer at LaingBuisson. I am joined by Kelly McCabe, CEO and co-founder of Perci Health, and Charlotte Burnett, the health and public sector partner from DAC Beachcroft. This webinar, for those of you that are asking, is available on demand. Notably, on our advertising, we mentioned that we'd also be joined by Darren Stapleberg, CEO and founder of Sevacare. Unfortunately, Darren hasn't been able to join us last minute. For those of you that were hoping to see him, I'm very sorry. We are hoping and working with his team to get him to join the second of these webinars that will be held on the 10th of December. With all of that, I'd like to hand over to Kelly to introduce herself as the first of our panelists. Kelly is the CEO and co-founder of Perci Health. And Kelly, hello.
Morning, Theo. Thanks so much for having us this morning. So yes, hi everyone. I'm Kelly McCabe. I'm co-founder and CEO of Perci Health. We are a UK-based virtual cancer clinic delivering a range of specialised cancer services which complement traditional cancer pathways. I have almost now 20 years of direct cancer care experience, so working in both the NHS and in private cancer hospitals in both clinical and hospital management roles. So I guess this morning I'm bringing an oncology-focused lens and understanding of the healthcare investment landscape to this conversation, and hopefully drawing on some very recent experiences of partnering as an independent provider with the NHS. So thanks, Theo.
Fantastic, thank you. And over to Charlotte. Charlotte is a partner at DAC Beachcroft. Charlotte, hello.
Morning. Thank you, Theo, and welcome everybody. I'm Charlotte Burnett. As Theo's mentioned, I'm a partner at DAC Beachcroft. We are a full service law firm specialising in health and social care and wider public sector legal services. Like Kelly, I've been doing this for about 20 years. I absolutely love my job, and I'm here to bring a legal lens on the 10-year plan and how that might affect us all going forward.
Fantastic. So yes, obviously missing Darren, which is a disappointment, I'm sure, which leaves this webinar as more looking at the infrastructure behind and the workings of the NHS 10-year plan rather than purely about the delivery of it. Delivery will be the main theme of our next webinar. With that in mind, I'd like to ask, I'm aware you're a bit of an expert on this, Charlotte. Could you give us your thoughts and a bit of an overview of the NHS's 10-year plan?
Thanks, Theo. So we saw the biggest consultation in the context of the NHS, which launched in the autumn last year, which has led to the publication of this plan around the new Labour government's health mission. Essentially, they have three what they call radical shifts but actually I think we've seen over the course of my entire career actually doing this, it's shifting that massive ambition of hospital services to the community, and how do we actually deliver that? I've got a lot to say about neighbourhoods. I like to think that I'm an expert in relation to integration, but have genuinely been doing this for about 20 years. I talk a lot about trust and relationships, which I think is going to come up a lot over the course of the next hour. But it's really about that shift of hospital services to community services and wrapping around patients to improve benefits for patients. Moving analog to digital, there is lots of talk about the single patient record, which is a really, really ambitious program we'll talk a little bit about in a minute, and moving from a sickness agenda to a prevention agenda. Again, really ambitious. For me, there is a lot about neighbourhood health in the 10-year plan, which is really interesting. It's about how you guys can all collaborate together to really deliver the best outcomes for patients within populations. There's also quite a lot of changes around things like pricing, what might be done on that in the future. And again, there is the single patient record, which just is woven through all of the chapters in the plan and is really good to see.
Brilliant. Well, thank you for that. A question for both of you actually, about the independent sector and how it all works. Where do you see the independent sector as a partner in achieving the 10 years plan's goals? Or do you see it more as a pressure valve that's going to relieve strain on the NHS's capacity? Charlotte.
Do you want me to go first on that one?
Yeah, please.
Okay. So I think there will always be an argument for the independent sector being used as a pressure valve, if I'm honest. And I think most of the attendees on this call will be really disappointed if I didn't nod to that. Historically, that is something that we have seen. However, I would like to think that in achieving the 10-year plan, it has to be done through partnership. I've talked a little bit about the neighbourhood health arrangements. We've got lots in there about single neighbourhoods, but if I talk a little bit more about multi-neighbourhood arrangements, we're talking about populations of about 250,000. If we go back 10 years, we were talking about accountable care organisations, integrated care partnerships. I don't think we're going back to that kind of structure, but I do think that there is the opportunity, which we started to see fledgling about 10, 15 years ago, starting to come through now. There is much more of an opportunity for providers to work together collaboratively to deliver the best benefits for patients. We're seeing lots of questions on this, on how can providers work collaboratively. And I am talking about the independent sector, the NHS, social care, local authorities coming together as providers in that market, care home providers, GPs, the whole VCSFE market actually talking to each other and saying, we can bring this to the party and we can bring this to the party. So it's looking a lot more like a multidisciplinary team wrapping around a patient, and how can that be created in a legal concept? So for me, it is all about partnership. What I would say is that that is only ever really built from real trust and relationships. We've seen a lot of this over the course of my career. And where we've seen it be really successful is where you have really good, strong relationships with really good, strong conversations between partners. That does not necessarily mean everybody getting on all of the time, but having robust conversations at the outset and saying, this is what we would like to do, this is how we think we can make it work, sharing control and sharing risk and reward in those arrangements, which I absolutely think can be done without one partner having to take over and being seen as, we are the driver of this, everybody else is in the back seat. I think we are in a position now, certainly from a legal perspective, where it is easier to collaborate than it has been previously. So in short, hopefully as a partner, but I'm confident on that one.
Okay, thank you for that. Kelly, I'll look to you for your thoughts on this.
Thanks. Yeah, thanks, Charlotte. I think I echo all of that, which is I strongly believe it's both. You know, the independent sector can absolutely act as a partner. We've got evidence of that already, but obviously will continue to act as a kind of pressure valve as well. I was thinking around examples of where we've seen great practice for independent partnerships with the NHS. And I think the greatest example, you know, pertinent to the work we do at Perci, is the NHS diabetes prevention programme. You know, it's one of the most successful national public health interventions in recent years. And it worked, I think, precisely because of the partnership between the NHS and independent providers. You know, I'm not even sure whether everybody realises that most of that care was delivered by independent partners to NHS patients. You know, the NHS designed the framework, the national standards, but they didn't try to deliver it all in-house. You know, they commissioned independent digital first, you know, obviously, providers to deliver that locally. And I think that model, you know, where something is specified centrally, where it's locally commissioned, and then where it's privately delivered, might be controversial, but I think that is a real advantage. And it meant in this programme that we could mobilise capacity at speed and scale. So within 3 years, that programme became a national programme, which is really, really rapid. I think what the independent providers bring is agility. It's obviously technology, innovation. They were introducing things, you know, at a time when, and now it's the norm, but then it wasn't, things like digital coaching, app-based tracking, you know, wearables integration. So looking at the data from that population. And obviously the NHS was ensuring that kind of clinical quality and equity. To Charlotte's point about risk and reward, the other thing about that programme is it was outcome-based commissioning, right? So people were being paid when, you know, patients were completing the programme and when certain outcomes were being achieved. So we were driving accountability through that way. And there's been a large-scale study published this year, the diploma study, showing that it was cost-effective and that we're likely to see continued cost benefits for this, you know, over coming years, because it lowers risk of other long-term conditions, not just diabetes. So I think, you know, here is a great example of where independent providers are acting as a strategic partner and supporting that NHS long-term plan that kind of move towards prevention rather than reactive care. Now, I find this very interesting because I have an aspiration that for things like cancer risk reduction, cancer support and survivorship care, that we could absolutely adopt a very similar framework. I think when it comes to acting as a pressure valve, I think, as Charlotte said, you know, that's probably more well known, like that's kind of taken for granted that that's what the independent sector does. I think we're seeing a very interesting use case, particularly where we work, so employer-funded healthcare. We're starting to see this real impact on supporting people back to work. So being this intersection between the National Health Service and obviously this Get Britain Working initiative, where we're focusing on tackling economic inactivity and addressing ill health. So there's about, I think, just under £300 million that's been allocated, you know, funding to support these Get Britain Working initiatives and work with ICSs to, you know, and the Department for Work and Pensions to deliver. And again, I think the independent sector has a huge role to play here. You know, we know that we've already been doing this for decades through, you know, private medical insurance plans, through occupational health services, increasingly through clinical rehabilitation that's delivered through other insurance types like income protection, for example. And, you know, one of the ways that we're seeing at Perci that we're easing pressure on the system is through our return to work outcomes. You know, we developed a proprietary return to work program for people with cancer, and we've found that over 86% of them return to work within 6 months. So the economic impact of that type of intervention is vast. You know, I think a recent report by Breast Cancer Now linked, you know, return to work outcomes or giving more support to get people back to work after breast cancer diagnosis as the second most impactful intervention. So saving the economy about £411 million per year. So it's the most impactful intervention after rolling out more screening. So I think, again, just another example of how the independent sector can also be a partner, but can relieve pressure at the same time.
Thank you. I suppose linked to that, obviously Percy Health does specialised post-cancer care. Um, how do you see independent digital services like yourselves fitting in within the NHS ICS system? And then what challenges are you seeing to that?
Yeah, so obviously my lens is very specialised within the sort of cancer care delivery element. So a quick piece of context for those listening around what Percy Health is and what we do. We provide a range of services really focused on trying to mitigate the rising cost of cancer on healthcare systems. So we provide services that help to detect cancer earlier, things such as screening and genetics counselling. And we also provide a range of clinical care to improve outcomes for those with a cancer diagnosis. So things like preparing for treatment, better tolerating treatment, and recovering and rehabilitating afterwards. We've been operating now in the independent sector for 5 years. We currently partnered with some of the UK's major health and protection insurers and large employers. And that means that today, over 2 million people could access support through Percy Health for free at the point of use. And I think that's a really important part of how the independent sector can improve health outcomes, sitting outside of the NHS. And that sort of experience in the independent sector has enabled us to capture very rich data on clinical effectiveness, but also on the economic impact of the services that we deliver. And as a result, earlier this year, we partnered with Macmillan Cancer Support to begin testing how our model could translate into NHS cancer pathways and obviously support the charity's ambition to reach everyone and to tackle that inequity that exists in cancer care. So we're now beginning to work with several cancer alliances and integrated care systems and starting to test on how this works. So sort of drawing upon those recent experiences. I think the model that we deliver was obviously designed to complement, strengthen NHS cancer pathways. It directly supports those 3 big shifts that Charlotte's touched on, this idea of moving care from hospital to home, focusing on prevention rather than sickness, and moving from analog to digital. We're a fully digital virtual service. And why this is very important for the integrated care systems that we're working with is because what they're seeing, and this won't be exclusive to cancer care, but there are some big shifts happening, which mean that the integrated care systems need to deliver care in novel ways. So what we're seeing in cancer is massive growth in the population of people living with and beyond a cancer diagnosis, driven on the one hand by increasing incidence, but on the other by these radically improved survival outcomes because of our treatment advances. So we now see, more than 50% of people going on to live for, over 10 years after their diagnosis, and certain types of cancer like breast and prostate, we're seeing survival rates of just under 100%, if detected early. And then on top of this, we're seeing, more treatments moving to chronic therapy, so requiring long-term support and surveillance in the community. We're seeing novel therapies being introduced that have whole new constellations of very long-term complex side effects. And we're obviously therefore seeing a greater proportion of cancer care being delivered outside of the hospital setting and in the community. This population has a high level of multimorbidity. So we know that 2/3 of people who live with cancer have another long-term condition. So you can see from an ICS perspective, it's a very complex, costly challenge for them and for the cancer alliances that they work with. And I think the role for digitally enabled services like Percy and others is that we, using our technology, can really extend the NHS workforce capacity. We can support with that continuity of care when you're moving someone beyond hospital treatment, capturing continuous data as we move people throughout the system and enabling, better service delivery planning, more proactive intervention, and ultimately lowering healthcare costs. There's already a real focus on this from almost all of the cancer alliances across the country. So there's an opportunity for digital providers like us to support this agenda. I think if anyone's really interested in this area, I would look at the Improving Cancer Journeys project, which is being funded by Macmillan Cancer Support. It's being led by UCL partners, and they're really looking at how they can improve cancer treatment outcomes, specifically in deprived areas, with a real focus on how we prevent or lower rates of treatment attrition, so people dropping out of cancer treatment. And again, a lot of that dropout is driven by unmet psychosocial needs. It's driven by, caring responsibilities or financial strain, which mean people need to go back to work and drop out of their treatment. So again, these sort of digital models like ours, where you're capturing all of those psychosocial needs, you're delivering that vocational rehabilitation, and addressing that large care gap, fits very, very well here.
Okay. Thank you. That was fantastic. Thank you very much. Charlotte, you're obviously coming at this from a more legal and regulatory perspective. What are you viewing as the biggest enablers, or I suppose potentially blockers, to collaboration between the NHS and the independent sector in the delivery of out-of-hospital care?
So it's a really good question, Theo, and I think everybody expects that I'm going to say, well, the biggest blocker is procurement. And actually, I think if procurement is planned well and executed well, I think procurement can be both an contracting authority, NHS perspective, friend, and actually it can work well for suppliers. I think we've become quite scared of it and quite risk averse around it. But if you understand it and plan it, then actually I am a true believer that procurement is your friend. What I think is the biggest enabler, I've got two things I want to say, and one I've kind of half written in my head. So whilst Kelly's been talking, it really is trust and relationships. It's having that understanding on the ground of partners that you are working with. That will lead into contractual relationships. It will look at models. How do you make that work? And at this point, enablers and blockers, it depends how it's done. If you try to quickly contract, think everything's going to be okay because you're getting on with your partners at the time, and that then changes, we would always advocate for get the document done properly at the outset. Hopefully you will never read it and it will just stay in a cupboard. My best work hopefully stays in cupboards and is never read again. But really it's making sure you think about things like who's got clinical responsibility for patients, what your indemnities. Kelly's just talked about extending workforce capacity, which is massively important. We've only got the workforce that we've got as a total across the country. It's going to be really difficult to expand that, and particularly expand that with any kind of speed. So it's about working collaboratively together, but actually having employers being in a position and staff being in a position that they know who their employer is. And then we come back to clinical responsibility and who is responsible for patients at what point on a pathway. Joining and leaving collaborations, again, really important, because if somebody might decide that they're not going to be involved in a particular collaboration at one point, but they may want to come back at another point, again, it comes back to those trusting relationships. So that was my kind of initial point, which I think is so fundamental to delivery of the 10-year plan. But the other point is these conversations are incredibly useful. Listening to what Kelly's been saying about the work that she's doing at Perci is really valuable, and having these conversations, taking from what Kelly said, the learning and managing to replicate that is so important. She talked about being hyper patient related, hyper patient focused. It's about education, it's about the workforce, it's about deprived areas that people live in, and it's taking those examples, and I'm conscious she made another example about this earlier, that we have this opportunity to look at patient populations. Things are very different in Grimsby to how they are in central Manchester, to how they are in London, to how they are in Bath. And we need to understand that those things are different, and different can be good, but we've got to really kind of embrace those case studies. And I am a big advocate for not necessarily 1,000 flowers blooming, but taking really good case studies and making models from those case studies, not there just being a single imposed model from the top down. I absolutely don't think that that is where this 10-year plan is heading, but I do think sharing those stories, sharing how models work is a massive, massive enabler. So I'm grateful to LaingBuisson for inviting us today and for having this opportunity. I do love these kinds of conversations. The other blocker which I do see is a personal blocker. I think we've got so much change going on within the NHS. We've had the announcement around NHS England and the Department of Health, the ICB blueprint. I think there is an impact to that, and I think we need to be careful and kind to each other, because at the end of the day, there's only so many people in the workforce, and some of them are going through a really difficult time at the moment. And then the final thing on my list that I just wanted to talk about a little bit was the shift to outcomes-based contracting. Again, something which Kelly's brought up. We have definitely seen this shift over the course of the last 10, 15 years, from input-based contracts to output-based contracts, and now increasingly to outcomes-based contracts. And I think with outcomes-based contracts, and looking at populations and prevention for those populations together with the left shift, I think that will be a real driver and an enabler for services going forward.
Okay, fantastic. Thank you. So those are all the questions that I had for you. When we opened this up as a thing to register to, we asked the audience to send us any questions they had in advance, as well as being able to ask them online. There were a few that I sort of really thought were interesting and wanted to pose to you. Charlotte, I suppose this one is, I probably want to ask you this first, because it links to what you were saying about the NHS is changing a lot and we're developing and moving. We are moving to outsourcing to the independent sector a lot more. Is outsourcing it? Do you see this as a risk of the NHS moving towards privatisation? And do you think that is undermining its core principles to a degree?
So I think that there is a definite shift to more care being provided in the community. I wouldn't say that that is a pure outsourcing or a move to privatisation. I think we need to move away from the narrative of privatising the NHS. I know that there are lots of central messages about the importance of all of the partners who deliver healthcare to patients. And we need to look at it as that partnership that everybody wraps around a patient and a service user for the benefit of that patient on a pathway. And I think that's a really important part of the narrative. And I think it becomes more important as this journey goes on, because we're not in an environment like we potentially were when we started our careers on, let's talk about pump priming, let's talk about additional money. We're not, unfortunately, we're not as a country in that space. We have an aging population. Demand is higher than it used to be. There's not the additional money. So, and I'm very conscious in the Q&As, I'm going to try and answer another question at the same time. It's not about where we shift money to or there being winners and losers. I think this is a really integral element that we've got to move to risk and reward sharing. So it's not moving money from one place to another. It's making sure that the services are done at the most appropriate place in a pathway, and that on that journey, there is risk and reward or risk and gain share to make sure that everybody is funded in the right way. And I absolutely accept, having done this a few times, that getting to a fair shares position or getting to that position where everybody's happy isn't something that can necessarily occur on day one. And there's lots of challenges with that. But again, that's why I go back to trust and relationships. So it's really difficult, is the answer to the question in the Q&A.
That makes sense. Kelly, I'll pose the same question to you then. Is this privatization by stealth, or is this something else entirely?
No, I agree with Charlotte's sentiment that we should move away from that narrative and that stigmatization of, private care delivery versus NHS. I think, this conversation hopefully is an optimistic one around the fact that the independent sector can absolutely support the NHS in its longer term ambitions without detracting from obviously the core ethos of like why the NHS exists and what it's there to do. I think we've got several examples where independent service delivery or privately funded service delivery can really support NHS patient pathways. So I talked about the diabetes prevention program. I think cataract surgery, for example, has been a really successful, these sort of standalone interventions where there are long waiting lists and large geographical variation, and an independent provider can come in and deliver very high quality care that lowers waiting lists, that improves patient outcomes and eases the pressure on the NHS. There are multiple examples of where that's been very, very effective across the NHS. So I think, I'm probably biased, right, in my perspective, but I'm fully supportive of, certain specialist services that can kind of just plug in to traditional NHS pathways being able to be delivered by private providers, with the heavy caveat, again, as Charlotte said, that there's high levels of accountability, right? That the pricing model is appropriate for the NHS, that there's appropriate risk and reward sharing, and that there's an outcome capture. So we're demonstrating all the time that private care delivery is improving outcomes for NHS patients. So I think that's really important. I think something that I think it's just really interesting. I've been having many conversations, particularly with Macmillan, around this over the last 12 to 15 months, which is when you are an independent provider, so you're innovating in healthcare, where do you begin? Because it's very challenging to begin an innovation like this within the NHS setting, particularly in the landscape where we are today. And so this idea of perhaps you start building, testing your innovation outside of the NHS. You gather that data you demonstrate effectiveness, and then you start testing it in NHS settings. I think that's a really important move that we should be supporting. We should be putting more investment there, and we should be supporting that, because that innovation, that testing that happens outside of the NHS doesn't cost the NHS anything, but actually the NHS can learn from the findings, the data capture, and so on. And so again, how can the independent sector support that innovation by moving faster, testing new models of care more quickly, capturing that data, and then supporting that transition from a purely private service into an NHS delivered service as well. And I think, that's what we are experimenting with currently, and there are many other health tech innovators doing the same. I think if we don't get comfortable with that, ultimately what's happening is lots of the good innovation is moving outside of the UK. So we're seeing brilliant healthcare, health tech companies that have been founded in the UK and within a few years have moved to the US and to other markets where they're kind of more ready and able to test that innovation. So hopefully that's given my steer on.
That does. And something that's come through on the Q&A that I suppose pulls on your answer. Cancer is so diverse in nature with different treatments available. What are the overarching outcome measures the NHS need to see in order to invest in this?
Yeah, and I think that's a really good question. And it's one of the absolute complexities and challenges of the field that we work in. Anyone working in cancer care will be impacted by this. Again, a great comparison with the diabetes prevention program. There's a single outcome measure that you're looking at, and it's really easy to track whether your intervention has had, a meaningful impact, not just on the patient, but on the economic outcomes as well. Whereas with cancer, you're talking about hundreds of different types of disease, thousands of different treatment combinations, and a variety of different important outcome measures at different stages of the pathway. And so, yeah, identifying that global outcome measure is quite challenging. I think obviously we should be looking at survival outcomes because our survival outcomes are lagging behind other developed countries. So that has to remain a focus. I think there should be more focus on quality of life measures. So we have the National Cancer Patient Experience Survey, but again, it's really just looking at that immediate phase when someone's completed treatment or had recent treatment in the hospital. But what's happening afterwards in that 5 to 10 years after a cancer treatment? Personally, I think we should be looking at return to work outcomes, right? But return to work is an independent health outcome, and we don't have good data about how well people are supported to get back into workplaces. I think one of the things that we are starting to talk to partners about is that we, with cancer particularly, but I think this might happen across other areas of healthcare as well, is that one of the challenges to adoption is that we're still seeing kind of the adoption of point solutions. And I think it links to this question. The reason people adopt a point solution is because by doing one small thing, you can capture one outcome measure and you can show a change. So you end up with multiple point solutions across a patient pathway. So for cancer, we might have solutions that, or, we might be measuring things like early detection rates from screening services. We might be looking at prehabilitation services and the impact on recovery after surgery. We might be looking at remote patient monitoring and the impact on somebody's treatment tolerance and quality of life. But we're doing it in isolation. And actually, I think a pathway-led approach where you're looking at the combination of all the different evidence-based interventions across a whole pathway can have a much more accumulative impact. So not just in terms of, we're not then diverting resource to lots of different mini projects, we're actually aggregating that resource, but we're also using one digital platform, one workforce, one project funding to deliver outsized impact across a whole pathway. So yeah, it's really complex, but I think we should embrace that complexity. And instead of doing small projects, think much bigger, much broader across the whole cancer pathway.
Fantastic. Thank you.
Theo, can I just come in on that? So there's a question in the chat around what types of services are best suited to transition from hospital to community delivery in the next few years. I'm not sure if you were going to pick up on that one, but I think the point that Kelly's just made answers that question. And I think it's those pathways. And I think it is probably going to be a case of undertaking the transition at a pathway level to start with. That are those which go first, if that makes sense. So the other one that I increasingly hear about is people with comorbidities and frailty, for all the reasons that Kelly's just mentioned as well.
I'm glad you brought that up. It was the next question I was going to ask.
Okay.
Perfect, thank you. So I'll go on to the one after that. Both of you actually, how do you see the role of GP federations within this? They sit in a slightly strange area. They're part of the NHS family, but they're independent sector bodies. How do you see that working?
So shall I go first? Is that okay, Kelly? So I see them absolutely as a partner in these organisations. So I think there is, I know there is quite a lot in the 10-year plan in relation to single neighbourhood arrangements. So we're looking at populations of around 50,000. And I think that is somewhere where GPs will absolutely be dominant. And if I put that to one side a little bit and look at bigger populations, G federations are absolutely going to have to be partners in neighbourhood arrangements. They have the core understanding of the gateway to the NHS. They understand the care pathways. They're working regularly with people across those care pathways. And I think quite often, one of my best friends is a GP. She talks about actually having the understanding and having the visibility, because I think they do have some of the better technology that they can see at the moment. Very, very confident about what's coming on the single patient record. But at the moment, I think they do have more visibility than other partners in the system. And so we're going to have to find a way to capture that information and share it, to make sure that we're not replicating and duplicating care in the system, where actually that could potentially be taken out and refocused in a different way. But I absolutely see GPs, GP federations as partners in this, in the same way that I talk about all other partners. I don't think that they should be excluded in any way because they happen to be they can elect to be regarded as an NHS body, but they are, of course, independent contractors to the NHS.
Kelly, thoughts? Agree, disagree, somewhere in the middle?
No, agree with Charlotte. Nothing much further to add on that, I don't think, other than, I think, yeah, that shift into primary care, we're going to see more and more. So how do we ease the pressure there? And, I think often this is where we're closest to the outcomes that matter most to the patients. We're closest to their real life and the things that matter most. So how can we leverage, as Charlotte said, like the data that's captured there to make sure that it's informing, best practice across the whole system?
Makes sense. So one more specifically for you, Kelly, that's come through on the chat and links to what we've been talking about this move to digital. How do you, as an organisation, serve these larger rural communities with higher levels of digital poverty, especially in older adult neighbourhoods?
Yeah, this is a really I'm really pleased it came up, because I think there's a really interesting discussion to be had here around adoption of new technology and innovation within a system that is supporting very, very diverse populations, and that, I think, obviously digital care can improve access to healthcare for the majority, but there will still be pockets of people where there's digital exclusion, and actually we could be at risk of enhancing inequity of access to care. So a lot of the work that we've been doing, again, with Macmillan Cancer Support, is looking at their key focus audiences, these groups that are harder to reach, that are typically underserved, and looking at how what we do can be adapted and tailored to reach those more difficult to reach groups. Having said that, I think it can be a barrier to innovation if we adopt this stance that in order for something to be rolled out, it has to be perfect for everyone. It has to work for everyone. Otherwise, we're not going to do it at all. Because I think what you're missing there is the nuance between, by improving access to care for the majority, for people who are willing and able to use digital services, or, and actually that might be their preference, for people who have lower complexity needs that, if managed early, will go on to be, not have any downstream complications. If we can leverage technology and innovation to manage that, we ease pressure on the system, we lower healthcare costs, we're then able to redirect that resource to localized programs for difficult to reach communities that have higher levels of more complex healthcare needs. So my view is, yes, we're never going to reach everyone, and I don't know any solution that does. Most NHS services, sadly, don't reach everyone, right? That's why we have the huge inequity and geographical variation that we're trying to address. And if we block innovation by saying, in order for this to be used, it has to reach everyone on day one, I think that could be problematic and it could slow us down. I think what we absolutely should be doing in all testing, piloting of novel services is looking at who is being excluded from this innovation and what are we doing alongside this to make sure that we are improving outcomes for those groups as well, and being very clear in the outset of any pilots or any testing, which group are we looking at and which group are we not, and making sure that then there's future plans to roll it out to more difficult to reach groups, and that appropriate, co-design and adaptations are introduced.
Thank you. Something that came up, it's not in the questions that are here, but we had a number of questions on this in the sign-up about how finances can be released from NHS trusts and sort of how would that work. Charlotte, I'll probably look more to you for an answer on this.
Yeah, that's fine. Thanks, Theo. So increasingly the answer is moving towards risk and gain share models. So if you have a service which, let's say, an NHS trust accepts should not be delivered within their community, their legal entity at the moment, it should be delivered by another partner within the population, the community, the neighbourhood. There are models which can be created whereby partners collaborate and you move to a risk and reward sharing arrangement. As I mentioned earlier, I think there has to be some kind of understanding that if we're moving from acute care to community care, NHS organisations will be in a position where they have staff, they have interdependencies, and you can't just flip a switch and say, delivery here one day, delivery there the next day. There's lots of things like DUPE, and employment lawyers will jump on me at that point. I am not an employment lawyer. But there will be lots of costs related to that. Some of them will be more easily dealt with, and some of them will be much more difficult to deal with that. And I think we need to get to a position of understanding that actually this is where we want to get to. This is what our ambition might be. This is where we want to be in a year's time. Risk and reward can shift. I am confident and have seen examples of what end up being fairly complicated finance mechanisms at the end of the day with algorithms and all sorts in them around if these interventions happen within the community, it can prevent this happening within an NHS organisation. That's brilliant. We can write it down. We've got examples of writing it down, but you need the trust and relationships to enter that partnership and have a robust conversation which says, it's going to be some stranded costs on day one. This is where we're going to get to. This is where we want the outcomes to get to. This is how we're going to measure them. And this is going to be the reward at this point. I think the other really important point to mention in that is not everybody can shoulder that risk and reward in the same way that the big organizations can. I'm very conscious there's some comments in the chat about Companies House and the size of profits and things. But it is really hard for some organizations to enter into these arrangements. And I think we need to be really mindful of that because as Kelly said, as you've said, we've got absolutely coming through the chat and it's brilliant to see this works where we look at our communities and we design solutions based on best practice that's come out through other people's case studies. But we've got to have neighborhood related solutions. And so it's taking that, having the hard conversations and moving forward. But I do think it can happen. And we've got examples of where we've helped clients to make it happen. And those are some of the things that I'm most proud of in what I do. So if I just take another question from the chat, because it follows on, Theo. Somebody's asked about the benefits that I think there are on social care, independent and local authorities working with the NHS to create successful neighbourhood communities.
Yes.
I think there's a massive benefit in this. And I have had a look through the participants on the chat, and there's a couple of people who will definitely have heard me talk about this before. we have some clients who desperately want to talk about social care, about granny maintaining the tenancy in her own home. They want to talk about gritting roads and Meals on Wheels and granny never falling over because she didn't have to go out to get milk. So she didn't fall over. She didn't need a hip operation. And so the friends and family test wasn't relevant to her because she was safe. She maintained that tenancy in her own home. And they want to talk about toothbrushing in schools and the importance of that in deprived areas in schools. And so I absolutely do think there are benefits, but I think we've got to get to a position where we can have those conversations. And from a legal perspective, we don't make it terribly easy from a statutory organisations collaborating with partners to sit and have those conversations. It does sometimes take complicated governance models and legal documents, which I will go back to. I hope you leave in the drawer and never have to read. But the value of those conversations is absolutely immense. We have got clients who talk about granny's tenancy, who talk about gritting roads, who talk about toothbrushing, who talk about education, who talk about this guy talks about it a lot. I can see a tower and they don't have Wi-Fi in that tower block. That's the issues that sometimes we need to solve. So absolutely, social care, I can see the benefits. I think the struggle is how we quantify those benefits though. And I think that's really ambitious. And I think there's still quite a lot of work to be done with all of the people on this call to make sure that that happens. But it starts with a conversation. It starts with, it really does. It starts with trust and building relationships with each other.
Thank you. Kelly, I promise I will come to you, and this does feel like a third question for Charlotte, but I will come to you in a moment. Just something that has come up at the very start that I want to come back to. You've mentioned robust dialogue. It was literally the very first question that came through. Robust dialogue has come up a couple of times. Who will exercise leadership in that? How do you make it happen?
I think everybody has to exercise robust dialogue. I think everybody has got to enter those conversations and be prepared to say in an appropriate way and being kind to each other, but you've all got to hold each other to account on that. There can't be one party which holds everybody else to account, because I think at that point somebody will feel like they don't have the control that they want and their ambition is for, and then I worry that people who are really important in the pathway begin to think they're less important. So I think it's that strength of voice and challenge, but appropriate, robust challenge I think is a good thing.
Thank you. Really answered that question very nicely, and thank you. Kelly, I now turn to you to get your thoughts on sort of everything we've discussed in the last couple of minutes.
Yeah, of course. I think well, the thing that I was thinking the most about from what Charlotte was talking about with this, I think you used the word quantify, how do we quantify the impact of moving services into the neighborhood, and of the, hopefully that real evolution of social care, which is absolutely needed. And I think we have a very pertinent use case here to discuss, which is that one of the problems that we have encountered in trying to deliver innovation across the cancer pathway is that inability to quantify the economic impact, in a system where there are so many fires to put out, and so many problems to solve. Really being able to put a number on that economic impact from any new service is essential. But what that often requires is, and certainly what this neighborhood working model will require, is very, very joined up data, so that you can see healthcare utilization across, primary, secondary, tertiary care, community services, mental health services, and so on. And our experience is that quite often this joined up data is lacking. And I think this problem exists not just for cancer, this is everywhere, but for oncology specifically, we have very good data about the cost of cancer treatments. We have pretty good data about the cost of things like end of life care. And when you then look at published analyses on the cost of cancer, it's typically using both of those measures. But this idea on like the global cost of someone with a cancer diagnosis to the healthcare system is actually very, very difficult to understand. There's very little UK-centric recent published data. There's lots of stuff in the US. So there's a raft of papers in the US showing about 2 to 4 times increased healthcare expenditure for someone with a cancer diagnosis. But we don't have that joined up baseline data here in the UK. So trying to build a business case for some of these shifts or some of these new services is obviously very, very challenging. I think what we've been really buoyed by recently is we are starting to see with the ICSs that there are now some integrated data sets as well. So, for example, we've been doing some work with South West London ICS, and they are starting to join up the records for people with a cancer diagnosis across, the whole system, so that we can really understand and begin to track healthcare utilization and then compare this with some matched controls. So that's a really important piece of work that we're doing now. And what that will enable us to do then is to see very clearly, where are the differences in spend, where are the key points of value erosion, in the healthcare pathway, and then how can we appropriately target our interventions to those very specific areas where we're seeing a wasted resource and where we can definitely have an economic impact. So can we reduce A&E visits, GP visits, and so on? So I think a lot of work needs to happen around joining up those data sets for us to then really be able to, as Charlotte said, quantify the impact of new things that are being introduced.
Brilliant, thank you. So there's a question here. I think this is a really good question because we've touched a bit on trust, Charlotte especially. We've touched a bit on the finances of it and a few other areas. And I think this draws it together quite nicely, that we're seeing the independent sector can provide services for the NHS almost more cost effectively and at the same, if not a slightly higher standard than the NHS can itself. Is it politics that's stopping that expanding? Is it an unwillingness for managers to be accountable or to reduce their own costs? Is it this feeling that using taxpayer money for private healthcare is somehow dirty and we don't want to redirect it? Is that fundamentally a barrier that we're not going to be able to get past? Or is the solution we just need to trust each other more, we need to work better, or is there something else entirely? Who wants to take that one? Because that is quite a big question.
It's quite complex.
It is, yes.
I think, yes, I mean, with a balanced view, yes, there are many, many examples where the independent sector is delivering services in a more cost-effective way and where we're seeing improvements in patient outcomes, right? And that's the thing that matters most, not just the cost effectiveness, but are the patients getting the very best outcomes? So yes, that's true. Equally, you've seen NHS facilities where there are pockets of exceptional practice, where services are being delivered very cost effectively with very good patient outcomes, right? So I think that can exist in both the independent sector and the NHS. It's just not universal. And so how can we move to a world where, all care is being delivered more cost effectively and with good patient outcomes? And I think, building in the independent sector, we have some advantages, sadly, because we, having had many recent experiences of being in NHS hospitals and listening to someone else talk on this subject, when you are trying to innovate in that space, you are effectively trying to layer your innovation on top of like years of really embedded processes and culture and financial strain and challenges, and therefore it's really hard sometimes to push through that innovation. Whereas when you're perhaps developing something in the independent sector, you've got a little bit more control over the workforce, the technology, the resource. You might be better resourced in order to do that. So we have some advantages, and I think it's about how can we leverage those advantages to best support NHS pathways. I do still believe there's strong stigma against private care and the role of private care in NHS. We come up against that often. I think there's a question here about, profit margins for private companies, right? And of course, we would want all independent providers or all providers to be operating ethically, but equally there is a role for profit for good. And that if you're able to build healthcare companies which are profitable, they are therefore scalable, they will continue to be sustained and to have long-term, far-reaching, beneficial impacts on the NHS system versus, you know, perhaps an over-reliance on the charitable sector, for example, where we're seeing, you know, financial resources being soaked up and services being stopped. So I do think a conversation around this role of profit for good and how that can support our long-term ambitions is maybe controversial, but I think is a really important one to be having.
Thank you. Charlotte, anything from you?
I completely agree with what Kelly's just said. I think the only point I would add to that is the collaboration. I don't like to talk about privatization, but that debate about using the independent sector for good, it's not going away. You know, this is a conversation we have been having for decades. The conversation is more now than it was 20 years ago. We are heading in this conversation. It's really difficult for all of the reasons that Kelly's just said, that, you know, I think we could do a whole hour just on that one question. But I think, again, conversation is good. Opening up about this is good. Case studies are good. Having these kind of sessions are good. We've got to talk about it. It is what the future looks like. I am a huge advocate for collaboration and everybody being part of a journey and wrapping around the patient to make sure that we get the best patient outcomes for those patients in those communities, which are hyperlocal at the end of the day. Yeah, so perhaps a bit ambitious that I think politics won't get in the way, because I think it always will to a degree. But I think it's right that we work together for the benefit of patients and patient outcomes.
Makes sense. We have talked a bit previously about this is to sort of Ben Kent's question, more a viewpoint. Effective pathway navigation will benefit from digital capability. I think we've broadly agreed on that. Are there solution providers that's taking the lead in joining the dots on that? Are there any that spring to mind, or is it just something that we're all generally working towards at about the same pace?
Answered some of that. Well, certainly in oncology, yes, there are a range of service providers delivering navigation services. It's a discipline that is much more highly evolved in the US than it is here in the UK, but it's emerging, this sort of idea of cancer navigation as its own discipline in its own right, where you're really looking at how you can assess the acuity level of various patients as they move through a pathway and make sure that you're removing any barriers to that individual accessing the care that they're entitled to and that they need. And this also exists for other complex conditions. So I think we're seeing navigation services springing up from within the NHS. We're also seeing independent providers of navigation services. I think one of the challenges for the UK at the moment when it comes to navigation services is, there's a few. Well, one is this interoperability, you know, being able to see the patient's healthcare record and where they are in, you know, when they're in the hospital setting, when they're outside of the hospital setting, and being able to connect the dots. There is a focus on, you know, digital navigation, but again, it requires the patient to be very highly motivated and to be able to, you know, use those digital services and provide their own data and symptom reporting and so on, so that we can track them. I think one of the areas where it often falls down as well is in the clinician response to patient navigation, and something that we've seen, and I'd be really I think there's some published literature around this, but we're seeing it more and more often, again, might be controversial, is that sometimes a highly informed patient, a highly educated patient who is being navigated through the system in a strained environment can create almost a sort of immune response, so like generate antibodies. So sometimes clinicians operating in the NHS don't always like if a patient asks lots and lots of questions and wants to be navigated through their pathway in a different way. And I think if we are to truly embrace navigation services, there needs to be a global understanding that this is better for the patient and it's better for the healthcare system, and tighter integration between the people navigating and the healthcare delivery partners. I think the other thing, linking back to what I was describing earlier, is how do you measure the outcome of that navigation service? How do you measure the financial benefit that is bringing, the perhaps admissions avoided, interventions avoided, and so on. And that requires, again, that joined up data set and the ability to see what happened before navigation was introduced and then what happens afterwards.
Thank you. I'll probably make this the last question, but I think it probably ties it up quite nicely, because we've effectively talked about how well the independent sector needs to partner with people. And the question is, how does independent sector partner effectively with VCSE based in the community? How do you do that to improve community health, to improve resilience? And a subset of that, should that be a requirement for independent providers to be involved in that local community and neighbourhood level? Thoughts from Kelly? I'd probably go to you first.
I think it's challenging. So I don't think it should be necessarily a requirement. I think there will be a willingness from, as the system moves in this direction, there will be a willingness for independent providers to be involved with neighbourhood health, because as Charlotte said, that's hopefully where all interventions begin and all of that preventative care is being delivered, and all of the the improvements in social care and education and health literacy. So I think there'll be a willingness. I don't think it should be a requirement, because I don't think all independent providers necessarily have a role to play in that. Some providers are delivering highly specialized services that you would only ever see in in a kind of tertiary hospital setting. So I wouldn't go that far, but I think there will be a willingness for independent providers to do more once these sort of neighbourhood health communities are better established. What do you think, Charlotte?
I completely agree. I think mandating participation isn't where if you look at how you feel when you've read the 10-year plan, which I appreciate isn't necessarily where everybody goes first, but it feels more collaborative, less mandation, less you must do this, you must do that, we're going to change this, we're going to completely reorganize that. It feels like it's more population centric. I absolutely agree. It will be inappropriate for some independent sector providers to want to get involved in this, because, like you said, you might just be involved in tertiary services. That said, I absolutely know that people will want to be involved in a slightly different way. So I think it's about creating communities where we can draw on people who don't necessarily want to be an immediate participant. And I think that's important. I talked a little bit earlier, I think, about the ability to kind of opt in and opt out of neighborhoods. And actually, it might be really, really interesting for Kelly to be involved, and super hyper important for a particular patient group when we're looking at particular cancer pathways. But actually, then when you look at frailty, might be completely inappropriate, and you want to opt out of that. So what I would really like to see is the models, again, coming from the neighborhoods themselves and saying, actually, this is how we've done it. This is how we've created an environment where everybody's welcome, but not everybody is needed to be there all of the time, which I think is a very wordy way of answering that question. So apologies for that one.
No,
And
no,
I think that the third sector will have a role to play as well. So it's that the trio of collaboration between the independent sector, the obviously NHS and social care, but also charities, right? Charities have been trying to do a lot of this work in the community setting for a really long time. They often have very good, strong relationships with some of their local groups. So yeah, I think that it's the kind of advantage to working as a trio.
Yeah.
fantastic. Thank you. Well, we'll leave it there on the questions. Thank you both very much for your thoughts. That was genuinely very insightful. And thank you to all the attendees for coming, for posing the questions. They were some great questions, a few challenging questions, but that really great stuff. And I hope everyone else enjoyed that as much as I did. With this ending, I want to point out the next things in the path ahead. There is another webinar similar to this, growing slightly, looking more at the delivery of the 10-year plan and the actual implementation of it. That will be on the 10th of December. And then what's on the screen now, our out of hospital healthcare conference, that will be an in-person conference in London on the 11th of February next year. It'll be a full day. It'll be people you've seen and heard from here today and people in the other webinars, as well as a wider industry perspective. So I hope to see many of you there. Down at the bottom, interested in speaking, that is my email address. Obviously, a lot of people with opinions in the questions and some really thought-provoking questions. If you wish to get up on the stage and give me thoughts, please do drop me an email. I'd love to get as many different perspectives on the stage as possible. I do think that the takeaway from this webinar has been the answer is working together, talking to each other and collaborating. I hope, Kelly, Charlotte, you agree that that's what I've taken from this. So in exactly that vein, do drop me a line if you want to speak, if you want to work together and collaborate on that. Thank you very much. And on that, I will leave it there. Thank you.
Bye.